In this video, we will discuss central venous access devices. This is a lab skill that highlights the concepts of asepsis and fluid and electrolyte management. The outcomes for this video will be to identify the common types of central venous access devices that you may encounter in clinical and the differences among them, including when they would be chosen, and identifying common flushing protocols. So before I continue, I just want to get a disclaimer out there. You're going to hear me use both the term central venous access device and central catheter. I mean the exact same thing. So if you hear me using those interchangeably, that's why. All right, so the purpose of central venous catheters. It is important to know why your patient would have a central line. This is twofold. One, you need to make sure your patient still needs it. Then you're questioning yourself, do I need to advocate to switch to a peripheral IV? And then the opposite is your second reason. You need to know when to advocate for the insertion of a central line. So here are some various reasons why we would consider switching a patient from a peripheral IV to a central venous catheter. First and foremost is using IV therapies with high osmolarity. So those are your hypertonic solutions. Hypertonic solutions are used to reestablish equilibrium in electrolyte and acid-base imbalances. So quite often you'll see like electrolyte replacement solutions and sometimes parental nutrition solutions, so like a TPN. But because hypertonic solutions can cause severe damage to the vein, it is best practice to infuse fluids with an osmolarity greater than 600 through a central line. This causes hemodilution, which is what you want. Examples of these type of solutions include anything that has more than 10% dextrose, 5% protein, and then high electrolyte concentration. So if you have a high potassium, you might want to consider advocating for an insertion of a central venous catheter. The second one is frequent IV meds. So perhaps they're on prolonged therapy for a really stubborn infection that's not going away. Antibiotics would be given in that case. So if they're getting antibiotics quite frequently over a long period of time, a central line is more patient-friendly. And then the big one that most people think about is chemotherapy. So quite often patients undergoing chemotherapy will have a central line of some type, because also the chemotherapy kind of destroys the peripheral veins a bit as well. If your patient's receiving frequent blood work, a central line might be a good choice for that patient. Basically, you can use the central line kind of like a faucet to draw out blood, and you don't actually have to keep poking and repoking the patient. Large bore access. So I'm not sure if you've gone over before, but in emergent situations, you want to have the largest bore IV as possible. So sometimes you'll see people coming in with a 16 gauge IV, and that's been put in the field when they've been in a car accident or whatnot. So usually it's in emergent situations where we're like, we need to get fluids in and we need to get them in quick. And then the central catheter will be a great choice for that patient. Which brings us to the next point. So if they're in an emergent situation, most likely they're in a highly acute area, so like an ICU. Pressure monitoring is another reason why somebody would have a central venous catheter. So central venous pressure, or basically measuring how full the tank is one way you can do that, and that is measured through a contraption that you attach to the central line itself, or cardiac output. So that's putting in a pulmonary artery catheter, threading it into the central line, and then it will allow us to do readings of cardiac output. So often, you're not going to often see that in the settings you'll be going to as a student, but perhaps in your preceptorship, you'll be able to see this if you're going to an ICU, an OR, or an ER. The next one is lack of alternative access. So perhaps the patient is a pediatric patient or is elderly, and we just don't have the peripheral sites to be able to start a peripheral IV. So in that case, they might go to a central venous catheter. And then the last one is incompatible meds or multiple medicated drips. So if your patient is on multiple drips, let's say they have like an insulin drip and a heparin drip and all that kind of stuff, and you still want to have all these other IV meds, a central catheter allows us to do that because it has more than one port going through one area. On this diagram, you can see various sites to where a central catheter could be inserted. It's important to note that all catheters rest in the SVC, so the superior vena cava, with the exception of the femoral site. So here are just some different little sites here that we have. So this is an internal jugular, this is a subclavian, but this one's tunneled. Here is a PICC line, and then this is a femoral, which you don't see too often. A femoral site is inherently more at risk for infection just due to close proximity to urine and feces. So it's a site that you don't want to use too often, but can be used in emergent situations because you don't actually need an x-ray right away to start using it. Yeah, so these are all different places where a catheter could be started in a patient. And as I mentioned earlier, the tip always rests in the SVC, except for that femoral site. It's very important that the tip does not enter the right atrium. So sometimes that happens during insertion, it goes a little too far and it's in the right atrium, and your patient will present with typically tachycardia and arrhythmias because the tip is tickling the inside of the heart there. Now we'll go over the different types of central catheters. The first one here is a non-tunneled catheter. Non-tunneled central catheters are used in urgent situations, and they're often secured with sutures to start. So for example, your patient was perhaps in a motor vehicle collision or rapidly became unstable. They're often inserted at the bedside and are inserted percutaneously. Sites of choice include the subclavian, the internal jugular, or the femoral vein. The SC and IJ, so the subclavian and the internal jugular, require an x-ray prior to use. And I have seen the femoral used, as I mentioned earlier, without an x-ray. I once had a patient who had a heart rate of 215 with a low blood pressure. The patient was very unstable and was being bagged, and in that situation there was more benefit to start using the central line versus waiting for an x-ray. Generally, all catheters that are non-tunneled have multiple lumens, so that could be a double, a triple, sometimes a quad. However, those quad ones are quite expensive. Most often you're going to see a triple lumen, and it is used for short-term use up to 4 weeks. If the patient still requires central venous access after that, your role then would be to consider advocating for another catheter type, which we'll talk about further along. This catheter has the highest risk of infection, and it's mainly because it is so short. So as you can see right here, how short it is. I'll get my pen to work. But how short it is, it's kind of like a direct pathway right into the heart. So these ones require very frequent cleaning in ensuring that you're following aseptic technique when doing so. The second type of central catheter you might come across is a tunneled. A tunneled catheter means exactly that. It is surgically tunneled through the subcutaneous tissue to an exit site on the chest or abdominal wall. You actually will be able to palpate the catheter itself underneath the skin until the venous entry point. So that obviously requires surgery. It can be used up to 3 years. It is secured with a Dicon cuff. So that's this guy right here. So that's the cuff. What will happen is fibrous tissue will grow around it. So right into that part that kind of looks like a Q-tip, it will grow into there, and that's actually how it will be secured to the patient. So it's the patient's own body is securing it, which is why you can use it up to 3 years. What's really great about this one, it's because you're tunneling it, the tube tends to be more rigid and thicker, so it doesn't tend to occlude or compress. There's a low risk of infection, And terms you might hear in like report would be a Broviac or a Hickman. So those are brand names, and sometimes they are referred to that in the patient's chart. So if you look at this patient's chest here, it's inserted right at the part where there's that little cuff there, and then it's all tunneled up to the patient's neck there. A peripherally inserted central catheter is one of the next type of catheters that you may see with your patients you're caring for. I would actually argue this is probably the one that you're going to see most often during your career. A PIC, as it's commonly referred to, is inserted via a peripheral vein, so one of those 4 choices there. They are recommended for all infusion therapies up to a year. They have been inserted at the bedside, but more often you're seeing them inserted in radiology under fluoroscopy, and this has been shown to have better placement. So as I mentioned before, we don't want the tip to go into the right atrium. A PIC line actually has the highest chance of being put into the right atrium just due on its length alone and how you're inserting it. It's so far away. You need to have an x-ray before you use it. Oh, and another thing that's kind of interesting about doing it under fluoroscopy, at the Misericordia, there's actually a lot of nurses that run that clinic. So that's a very interesting thing to see. Now, you'll come across various types during your career. Basically, you just need to know whether if it's a closed or open PIC. So now you're going to asking yourself, what does she mean by closed or open, and how will I be able to figure that out? The easiest way is actually during your assessment when you're actually visualizing the site. If it is a closed PIC, there is a special end that has a valve in it. So a closed PIC will actually not have clamps on it. So that top picture on the left-hand side is a closed PIC. There are no clamps on the line itself. So that tells me I'm going to only have to flush it with saline. So examples of closed PIC brand names are a Gloshong and a Power PIC Solo. And the Power PIC Solo is a single lumen one, often seen at the Royal Alec. So just to be aware that it can come across as being a peripheral IV, but it actually is a central catheter. Then now that we kind of figured out, oh, this is closed, what's open? Open means just that, the end is open. Best way that you're going to figure it out when you are assessing and looking at your actual patient in the actual site is that it has clamps on the line itself. So you can see that on the purple catheter on the left-hand side, the bottom one. It has the 2 clamps on those 2 different lumens there. The open end at the end of the catheter actually causes turbulence with the blood flow, which could lead to clots. So whenever you see those ones with clamps on it, you know that you're going to be flushing with both saline and heparin or some other anticoagulant. Brand names that you might hear with this one are a Power PIC or an Arrow. And last, but certainly not least, is an implanted venous access device or IVAD. These are inserted in the OR for long-term therapy up to 3 years, and they must be accessed with a special needle. It's called a Huber point needle. It's a non-coring needle. This is probably one of the most costly options. You often actually see this in pediatrics. So far in my career, I've only accessed one of these once. What's really interesting about it is that you can palpate for the firm disc on the chest, and you can see that on that patient's chest there. You can see where it is, and you can actually see the line moving up towards his neck there. In pediatrics, you actually can put a numbing cream on there ahead of time before you put the needle in place. And that's what the needle looks like, is that second picture there on your right-hand side. That's what the needle looks like. In your lab practice for this week, you will actually have the opportunity to take a look at one of these. If you're accessing it, the needle's changed every 7 days. So it actually can just hang out on the chest there. If not being accessed, you must insert and flush the port every 30 days, which is why it's such a great option for our pediatric population. So flushing. Flushing is how we keep the pretty invasive line functioning. So this is essential and is part of our nursing responsibility related to this type of treatment. So central catheters must be flushed even when they're not in use. They're completed under clean aseptic technique. You're going to use positive pulsing pressure, so similar to what you learn when flushing peripheral IVs. But in this case, you're going to use a 10 cc syringe. If it's an open cath, so remember it has the clamp on it, so that's going to be your visual cue that you need to do this. For each lumen that's present, you're going to get 1 syringe with 10 mils of normal saline and 1 syringe with 5 mils of Heplox solution or 3 mils of sodium citrate, and that will be dependent on orders and the site you're at. So for example, if your patient has 3 lumens, so has a triple lumen, you actually will have to bring to the bedside 6 syringes. So that's just going to give you how much prep that is required to do flushing. If it's closed, for each lumen, you're just going to bring a 1 syringe with 10 cc's of normal saline. So when the tubes must be flushed even when they're not in use. If it's a non-tunnel catheter, so that very first one, it's every 12 hours. So remember how those ones have the highest chance of clotting off and having infection. That's why you're flushing them more frequently. If it's tunneled, it's every 7 days. If it's a PIC, open PIC, every 24. If it's an IVAD, as mentioned earlier, it's every 30 days. So these are just important things that you need to be aware of. But the general commonalities between all types of central catheters is that you're always going to use a 10 ml syringe, never smaller. So if this is a question on an NCLEX exam, you're going to put in 10 mils. A 5 mil, a 3 mil, and I don't know why you'd ever consider using a 1 mil, but just say a 1 mil, are too small. There's higher PSI on them, and they actually can cause the catheter itself to rupture inside the patient. This is why you're always going to use a 10 ml syringe. You're always going to use normal saline by itself or normal saline and some sort of anticoagulant such as hepaline or sodium citrate. And then you're always going to flush before you use it and aspirate back for blood return. Flush after blood sampling, administration of blood and medications, and TPN. So you're always going to flush afterwards as well. Thank you for sticking with me. I know this was a bit of a longer video, but now with this foundation, we can consolidate nursing concepts in our lab lecture. So in class, we will explore our responsibilities as a nurse in what-if situations. Thanks for listening.